Recording.
Hello, providers. My name is Heather Raley. I'm a behavioral health consultant with Mosaic Group. I've seen many of you around Fort Washington Medical Center over the last month since we've integrated our Reverse the Cycle program. I was hoping to speak a little bit more about that today and inform you of the next phase of the Reverse the Cycle program that will be officially starting at Fort Washington Medical Center on the 30th. Most of you will probably be seeing this a little after. However, I wanted to ensure that you're familiar with the protocol for our new MOUD, or Medication for Opiate Use Disorder initiation program that will be offered as of March 30th. So while you're familiar with the Reverse the Cycle program and the role of the peer recovery coaches, Michael and Amar, I'll be speaking a little bit more about another component of this program. So our goal is to understand the evidence-based Reverse the Cycle program and also the role the providers play within the MOUD initiation. So a little bit of background information. Over the last couple of years, to no one's surprise, we have seen a significant increase in substance use disorders, substance use, initiation of substance use, and overdoses. Just some quick facts and figures. At current times, about 40.3 million Americans do have a substance use disorder. About 4 million of those Americans received treatment, which equates to about 1.4%. Our goal with the Reverse the Cycle program is to identify and connect patients who are interested in and willing to seek counseling or treatment for substance use disorders and reduce the barriers. Drug overdose is the #1 cause of injury-related deaths in the US, and in 2020, we saw an increase by nearly 30% in overdose deaths, and unfortunately, Maryland was heavily affected by this increase as well. Prince George's County specifically, which a county that was fairly less affected by the opiate epidemic, saw an infiltration of opiates into their drug supplies. And so while many people in Prince George's County are not regularly using opioids, at least the numbers aren't as high as, say, Baltimore City or Baltimore County or Washington, D.C., we are seeing a significant increase in overdose deaths because of fentanyl being laced into several other products that are being sold on the street. Maryland in 2020 to 2021 did see a 21% increase in overdose deaths, and looking specifically at the capital region, we saw a 32% increase in opiate overdose deaths. We also saw a significant increase in emergency department related visits for opiate use. And I recognize that I'm speaking a lot about opiate use. However, this program is not specific to just opiate use. Our peer recovery coaches are seeing patients who come in with struggles with alcohol, cocaine, PCP, and even marijuana with the aim of reducing harm. So Mosaic Group in the state of Maryland and Prince George's County recognize the need for a more powerful response. And this program is initially funded for the first year through a grant coming down through the Prince George's Health Department. There are 3 components: universal screening and peer intervention, which went live on February 22nd. So it's been live for about 5 weeks at this time. Your peer recovery coaches, Michael and Amar, you've met. I'll speak a little bit more about them in a second. The Overdose Survivors Outreach Program, which I'll also speak to, and we'll spend most of our time discussing the MOUD initiation in the ED. So our universal screening and peer intervention, as you've noticed, there's now an SBIRT screen, which stands for Screening, Brief Intervention, and Referral to Treatment, that is required for all patients who come through the emergency department. Looking at the first 4 weeks of data or so, we've seen an increase week after week, which is really exciting, and the patients who've been screened. We've gone from high 50% of patients screened to almost 65% of patients screened. And so I'm working very closely with your nursing leadership to ensure that we approach our goal of 75% of patients screened. Any patients who screen positively, meaning they identify as having high-risk alcohol use behavior or any illicit substance use, the peer recovery coaches do meet with. They deliver what we call a brief intervention, and they're discussing any type of change that the patient may be willing to make regarding their substance use. Maybe that's just harm reduction, cutting back on use, and maybe that's anywhere in the spectrum up to interested in substance use treatment. And our coaches have referred several patients directly to treatment from the ED so far. Oops, skipped ahead there. So here are your peer recovery coaches who you've probably met, Michael and Amar. Their normal coverage is from about 8 a.m. until 11:30, not quite midnight yet. However, there are some days where there's only one peer coach on and they work a mid shift, either 10 to 6:30 or 12 to 8:30. Michael and Amar are individuals who are in long-term recovery themselves, and they've dedicated their life to help others achieve recovery as well. and they've had extensive training in motivational interviewing and substance use disorders. So what does it look like here? All patients 18 or over, as I mentioned, will be screened, and any patients who are screened and are identified as a positive screen will see a peer recovery coach. This expert screen looks like this. And so the first question asks, how often do you have a drink containing alcohol? If the patient says never, the nurse will move on to the drug questions. If they say they drink any amount, some additional questions will be asked. And this calculates a score ranging from 0 through 12. Right down here in the red box, the expert score calculates. If it's a 7 or above, it automatically populates that patient to the coach's multi-patient task list in Cerner. Additionally, there are 2 drug questions that are not scored. They're simply yes, no questions. So the score you see is simply the alcohol score. And then the drug questions currently ask, have you ever used any recreational drugs, illegal drugs, or heroin opiates for recreational purposes or non-prescription purposes? We're working with Adventist Healthcare at the corporate level to change these questions to say within the last 12 months and make some of their small tweaks to this expert screen. But for now, we're identifying any patients who have a history of any use, and the peer coaches will talk with them just about their substance use and anything they can do to support them. This bottom part of the screen, it does not have to be complete by nursing staff at all. It automatically populates if it's appropriate. And so if patients are 7 or above on the audit C, or say yes to one or both drug questions, are identified as positive. The OSAP here, the role of the OSAP here will be specifically to work with our highest risk patients. We do not currently have anybody hired in this position. The position is open, people are applying, and we are interviewing. We hope to have somebody in that position within the next month or so. This is more of a community-based role. While this coach will be in the emergency department, the goal is to really have them out and about in the community working with our patients who are overdose survivors, who are using opioids, who are using PCP, or who have come in intoxicated to the ED, and connecting them to any resources they're willing to accept help. The MOUD initiation, again, MOUD stands for Medication for Opiate Use Disorder, and our fast track referrals. So part of this program is to increase access to medication for opiate use disorder, specifically Suboxone. And so we've been working for a while with the pharmacy and also the Cerner team to ensure that Suboxone is available in the pharmacy, and it currently is available in strip form. There's a laundry list of research that supports that medication for opiate use disorder saves lives. And I have a number referenced here. If you'd like to look further, I highly encourage you to do so. But we know that the risk of opiate overdose death declines immediately when patients are initiated with buprenorphine treatment. And one of the ways we do that is in the emergency department. And this is a method that has been researched for years, proven to be effective. And we know from our program over the last several years in Baltimore City and around Maryland, that when a patient starts their Suboxone in the ED and the coach is working and sets them an appointment within the next 24 to 48 hours in the community to continue their Suboxone treatment, there's a 70 to 75% chance that they will show up to that treatment appointment and continue their treatment. As I mentioned, overwhelming research supports that this medication saves lives. It reduces mortality by up to 50%, and both methadone and buprenorphine treatment retention have been linked to decreased risks of death, and both medications reduce the number of opiate overdose deaths in the community. Treatment with methadone or buprenorphine is also associated with lower rates of opiate use, improved social functioning, decreased IV drug use, reduced HIV transmission, and a number of additional health benefits. There's a number of studies by Gail D'Onofrio out of Yale that shows the effectiveness of ED-initiated buprenorphine study. In a number of different studies, it does show that patients who are linked to treatment and continue treatment engagement at the 30-day mark is significantly increased with the initiation of Suboxone. There is a 3-day rule by the DEA, which I'll talk a little bit about. A number of providers are aware that there is a requirement for a waiver to be, an X waiver to be completed in order to prescribe Suboxone. This protocol does not require or request prescription of Suboxone. What this is, I apologize. What this is requesting is an administration in the ED for alleviation of acute withdrawal symptoms. So under the Narcotics Addiction Treatment Act of 1974, practitioners or providers are allowed to administer but not prescribe narcotic drugs to a patient for the purpose of relieving acute withdrawal symptoms. The treatment may not be carried out for more than 72 hours, and not more than 1 day's medication may be administered or given to the patient at one time. So how this protocol does work is that the patient would be administered that first dose within the ED, if appropriate, and we'll talk about the inclusion and exclusion criteria. And our peer recovery coach is working to secure an appointment in the community for that patient to continue their substance use treatment in the community after their discharge. The MOUD initiation protocol would not be initiated if the patient was not interested in continuing treatment or already connected to, say, a methadone program. So patients who begin to experience withdrawal can receive an 8 milligram dose of Suboxone to begin to feel better. This allows them to participate more actively, to understand the discharge instructions better. They're less likely to leave AMA because they're not feeling sick, and they're much more likely to connect to treatment the following day. Patients who do receive a dose tend to avoid illicit use because they're not feeling withdrawal symptoms, and they're less likely to revisit the emergency department. So after the consultation with the peer recovery coach, the peer coach will approach the provider and ask them to be considered for a dose of Suboxone. The provider can view the ED adult power plan under the ED medication for opiate use disorder induction adult power plan. Completing the required and applicable order details, then click on the orders for signature. Part of the inclusion criteria, as you'll see, is opiate dependent criteria or opiate use disorder criteria. And we've included that in this little notebook icon to the left. The exclusion criteria do include any patients with an altered level of consciousness, acute intoxication, if they've had methadone within the last 72 hours, severe liver disease, and having a short-acting opiate within the last 12 hours. The criteria for substance use disorder are included here. And this is something that the peer recovery coaches can discuss further with you as well, or myself, if you see me on site. We do ask that you add opiate dependence diagnosis, and this will be automatically placed opiate dependence uncomplicated under problems and diagnosis. Some information about how buprenorphine works. If you're not familiar, there is a ceiling effect. And so this means that patients who take any opioids on top of Suboxone, they are not able to feel the effects. They are not able to get high following administration of Suboxone, and therefore it does decrease the instances of individuals taking opioids off the street after being dosed with Suboxone. As noted here, buprenorphine still blocks opiates as it dissipates. There's no withdrawal pain. It helps ease withdrawal symptoms. And there are no negative side effects to Suboxone administration. There is a POWS assessment or a clinical opiate withdrawal scale that is required to be administered by the nurse prior to the provider approving administration. The goal is to prevent precipitated withdrawal. We know that withdrawal is more likely when there's a high physical dependence and the initial dose of buprenorphine is either too high or too soon to a prior use of opiates. And so in order to ensure that our patient will not experience precipitated withdrawal, we do require the COWS assessment to be administered by the nurse. The COWS assessment is very straightforward. It's very similar to the CWA or the alcohol withdrawal scale, and there's a screenshot on the next slide. The COWS assessment completed by the nurse is under ED frequent monitoring, and it asks for assessments, and there is a drop down under each, and you select the appropriate response regarding pulse rate, sweating, pupil size, GI upset, and you can see the rest of the criteria. The COWS assessment does generate a score, and a score of 8 or greater means that the patient is in withdrawal enough in order to be safely administered a dose of Suboxone. So the nurse would notify the provider that the patient is eligible. And in the meantime, while this is happening, The peer recovery coach is working with the patient and community-based treatment centers. We have a network in Prince George's County and in surrounding counties of substance use providers in the community who are willing to take our patients within 24 to 48 hours and connect them and continue their Suboxone treatment in the community. They will not recommend a patient to be dosed unless the patient has confirmed that they'll go to treatment and there's an available appointment. So in summary, nursing staff will screen all patients 18 or over. Patients that screen positive are triggered to the peer coach. The peer coach will conduct the brief intervention that may include MOUD initiation. The brief intervention and plans for follow-up, if appropriate, the OSAP coach will be referred the patient. If they're high risk, the PRC will provide the patient with a referral if appropriate, and the PRC will schedule and complete the follow-up. I have noted here our executive sponsors and our leadership involvement. Unmi Shim has been integral in bringing the program here. Anna has been a wonderful advocate and nurse leadership in order to integrate our screening tool and train the nurses. And Dr. Andrea Doctor is the current peer supervisor, and she's working very closely with the peer coaches from an administrative and a clinical standpoint. Again, my name is Heather Raley. Please say hello if you see me around the emergency department. I've been trying to meet the providers as I'm on site, and I encourage you to ask any questions at any point. Thank you so much for your time today.